Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Well, hello, everybody. We are here today with some of the most exciting things that I use in my practice, and a topic that has been exciting to me, honestly, ever since I was an undergrad in college. And I have a very special guest today who's helping me and helping you to really understand this fairly complex topic and how it can factor in, if you apply it correctly, to your own health, your heart health, your brain health, and of course, your overall health and your longevity. And my very special guest today is Dr. Sharon Hausman-Cohen. Dr. Sharon is a leader, an undisputed leader in the field of genetics and genomics. And if you were wondering what the secret topic is, now you know, right? You know, the secret is out. So genes, not the genes you try on, although, you know, knowing your genes could help you fit better in your material genes, but the genes that actually shape the trajectory of heart disease and a lot of other non-communicable chronic diseases, as well as give us an insight into what we can do through the lens of lifestyle, supplements, medications to actually overcome some of our own genetic vulnerabilities. Welcome, Dr. Sharon.
Thank you so much, Regina, for having me. I so appreciate it.
Oh, you're welcome. And so I'm going to ask you the same question I ask all of my guests. How did you grow up to be the leader in the field of genetics and genomics?
Well, I actually was always the kind of person who liked to understand how things worked. And I was going to become a research scientist. Before I went to medical school, I had the opportunity when I was in college to work closely and entertain. He was a visiting professor at my college, a Nobel Prize laureate, the person, Dr. Gerald Edelman, who discovered the immunoglobulin molecule. And he convinced me that because of my interest in science and medicine on such a molecular level, I should go do a PhD in medicine.
All right.
And I started out down that path. I went to Harvard's medical school, but to do a PhD. And I rapidly discovered that I liked too many things. There were so many topics of interest that I didn't want to spend my whole life on one protein. So I had, during college, done a lot of medical research, both with making drugs more specific for their receptors, which actually relates a lot to what I do now of figuring out how genes work and how you can address them. And also in the field of genomics. It was just really genetics at those days. We'll explain the difference between the two. And then so after my master's, I went back to Harvard to do a medical degree, became a family physician, which is the specialty of people birth to death is what I always describe. Also then became dual board certified in integrative medicine. But as the 23andMe revolution happened, people would bring me their genetic, genomics and say, can you help me prevent cognitive decline? Can you help me with my family history of heart disease, with macular degeneration, with, depression? And I started looking for tools that were out there that could help me use this really exciting information, of precision information, in a medical way. And there was no tool out there. So I, along with the co-founder of my practice, we decided to build one. And we thought we were building this, research database to use for our own patients. And very rapidly, we realized what a huge undertaking it was. And it became what is now known as IntellxxDNA, which is a clinical decision support tool that is highly evidence-based, highly accurate, geared at helping physicians like you and me and other healthcare professionals to make better clinical decisions that allow us to really practice personalized medicine.
Amazing. And, there are a couple of points we can infer from this. Point number one, if you want to get to Harvard Medical School, there is a roundabout way via the PhD track. I'm kidding. I'm
Actually,
kidding.
the funny thing was I had to take a year off because they made it very clear that you are not allowed to apply to the medical school while in any of their graduate program.
Right. So I said, the roundabout way, but, I'm kidding, of course, And point number two is, and that's a more serious one, is that there is absolutely a tremendous need for robust and verified clinical decision support tools, especially in the fields of genetics. So let's dive into it, because I think for our listeners, whether they're professionals, medical professionals, perhaps nutrition professionals, or non-professionals, just individuals who are seeking to optimize their health, I think there is a lot of misunderstanding and sort of mislabeling when it comes to genetics. Because I find, for example, that many of my patients, they think that genetics analysis is all the same, and they don't understand that that's actually not, and they don't actually necessarily distinguish between genetics and genomics, or even epigenetics. So why don't we go into this and maybe start with that second one? What are the terms? Genetics, genomics, epigenetics. What are we looking
And I
at?
think that's a great place to start because
Mhm.
geneticists even are not specialists in genomics. And let me explain the difference between genetic diseases and genomic diseases. So genetics has been around for a long time. The study of Mendelian, do you get curly hair or straight hair, and are earlobes attached? And what does your eyebrow look at? There are different traits and diseases that are inherited. And genetics is the study of inheritable diseases or inheritance in general. And so a genetic disease would be, for example, something like Tay-Sachs, cystic fibrosis, sickle cell disease, or even the BRCA gene that can be, that causes breast cancer. It is the study of specific genes that are associated with specific outcomes. And genomics is a little different. So genomics is the study of small changes in your DNA that occasionally there are some of the genetic diseases are due to genomic variants. But for the most part, genomics is the study of these one letter changes in your DNA that most of the time don't cause any disease at all. They might cause slight effects on a gene, or even a little bit more significant effects on the gene, that by themselves don't cause a disease, but together, when combined with diet, lifestyle, and each other, can be very significant. I think one of the best known examples of a genomic disease and the gene that people have all heard of is ApoE4 and Alzheimer's. I mean, if we could see the audience's hands, a lot of them would raise their hand. Yeah, I've heard of ApoE4, but ApoE4 is in 25% of the population almost. So it is not a pathogenic gene. It doesn't, a gene variant. It doesn't cause a disease. There was an article that came out saying, well, maybe ApoE44 is causative for Alzheimer's, but I can guarantee you it's not, because I have ApoE44 individuals in my practice in their 80s that are still in above the 90th percentile for cognition. But ApoE4, depending on what you have along with it, can affect heart disease. It can affect cognition. But there are gene variants that it interacts with that can double the risk compared to an ApoE4 alone. And there are ones that can cut it in half. And there are more than 8 or 9 of these different gene variants that are known to have really big interactions. So to know ApoE4 alone is not enough. But also, Brett mentioned epigenetics. Epigenetics came out as a term well before the human genome was sequenced. Yeah. And the word means on top of genetics. And epigenetics is the idea that we can modify our genomics or our genetics by what we do, by our diet, by our lifestyle. So the classic is people talk about methylation, but everything you do, if you eat more fruits and vegetables, if you eat more chili peppers, that lowers, well, it does. Chili peppers are really potent for lowering the expression of TNF alpha. lion's mane mushrooms lower the expression of this one inflammatory gene, TNF alpha. And why is that important? Well, there's a TNF alpha variant that can make your risk of Alzheimer's when combined with APOE4 6 times
Much higher. Yeah.
So then you want to lower it. So epigenetics is the study of how we can respond to our genomics. And in our IntellxDNA reports, everything we do, recommendations that are targeted to an individual's specific gene variants that relate to diet, to lifestyle, to supplements, and even medications, is really the science of epigenetics. How can we respond to this? We're inherit whatever genes we inherit, but you can have two people that have the same risk for heart disease or diabetes, and absolutely what they do with their lifestyle can make a big effect on how that manifests.
I agree. And, I always tell our patients is that in a way, genetics is sort of like an alphabet, like a language, right? Something is written in a specific language. But genomics is a book that tells the story. And in that book, that story is that what we follow. And like in any book, when you read the story, there are different interactions, of protagonist and antagonist, whoever they are. And in a way, it's like, a parable for epigenetics, right? So it is complex, but the great part about it is that we currently have tools which are relatively inexpensive that maybe just 10 years ago either didn't exist or were prohibitively expensive in hundreds of thousands of dollars. B, we now have decision support systems that when a patient works with a practitioner who understands this, could actually give both a patient and practitioner a path forward. And C, we now have a way to integrate all of this into kind of a broader context, right? The laboratories, the imaging data. And this is what we do a lot at Holistic Heart Centers. Obviously, the laboratory markers plus genetics plus our imaging data plus biometrics kind of puts the whole phenotype, if you will, together. But let's explain, to people who are listening to us, because this is an area where I think a lot of education is still needed. What are the different ways that an individual can obtain genetic information? And specifically, you mentioned already 23andMe earlier on. I was an early adopter. I was in exact same situation as you, realizing that what I needed and what I was given wasn't quite the same. We know that the company sort of went out of existence, but I think we have to give them recognition for being pioneers, right? For being the first ones, right? In bringing this direct to consumer testing into availability and into the market. So what are the differences? What is direct to consumer testing? What specifically people can get with that, and more sophisticated techniques like next generation sequencing, which is what essentially you're doing. How do we explain this? And maybe we'll start with just a very basic orientation to the DNA structure, right? What is the DNA structure? What are people looking at, and why? And we'll go into the direct to consumer and all other interesting types of sequencing.
Yeah, let's go back and talk about when I talked about a variant. The other name for that is a SNP, a single nucleotide polymorphism. Mm-hmm. What is that? So DNA is a bunch of letters. So you might think, how can we make whole human beings and every live creature in the world just out of these little, they're called nucleotides, these little base pairs that hook together? But think about computers. Computer language uses very few variables, and yet look at what it does. I mean, I can't remember if it's ones and zeros or I's and O's. I think it's ones
zeros and ones. Zeros and ones.
I'm not a programmer. But we have our whole world based on these very small bits of information and how they're put together. Well, for DNA, there's 4 different base pairs. And again, think of them kind of like that language, but they're symbolized by A, T, C, and G.
They're the letters of our language, right?
They're the letters of the DNA language. Yeah. And there's 3 billion of them that make up the human genome. Now, most of them stay the same in everyone. Otherwise, we would be crazily different. But there are about a little over 1 million of these base pairs that can alter between individuals. And those gene variants that happen when they alter. They might not change the structure at all, or they might have a very significant effect on the structure.
So it's a single place, right? I just want to make sure
so
that
a SNP is a single nucleotide polymorphism.
single one little place.
One little place. But the way that I describe it is one little place can do nothing. So if you think of a gene, maybe it's 40 or 50,000 base pairs long. So it's pretty long, and it's like a folded protein. And for those of you who are old enough to remember those ribbon candies that were all kind of folded, I think of DNA a little bit like that, but think of it as kind of something you could take it like a ball of yarn would be take a bunch of yarn and you clump it up, and it's kind of going in different ways. Mm-hmm. Well, our body really only has about, 28,000 genes. And so how do we make a human with 28,000 genes when there's so many things to do? Well, each gene can do different things. So I'm going to take the vitamin D receptor because everybody's heard of vitamin D. Yes. Well, vitamin D can't work alone. So vitamin D has its little docking station that it binds to called the vitamin D receptor. Mm-hmm. And vitamin D's job when it binds to its docking station is to turn things off. So if your vitamin D receptor isn't working, you can't turn things off. So if you can't turn off bone remodeling, you get osteoporosis. Right. If you can't turn off your immunity, you get autoimmunity. If you can't turn off cell growth, you can get cancer. So that's how vitamin D and its receptor, and even heart disease, vitamin D receptors relate to heart disease and stroke. Because if you don't turn off cardiac remodeling or different things, there's lots of stuff that
or plaque grows. If you don't turn off plaque progression, you get what follows downstream.
The reason that you can't just talk about a gene, but you have to talk about a gene variant is think of that tangled grouping of yarn. Well, over here, the grouping of yarn might interact with the receptors on the bone, and over here on the heart, and over here on the blood cells, and over here, on another area of the, immune system, and all these different things. So if you have a vitamin D receptor over here, you might, again, have osteoporosis, and over here, you might be more risk for autoimmune disease. So what the study of genomics is it's studying each of those little changes and which ones are important and what are they important for. Then what my area of research has been on all the gene variants, and we'll take a topic of heart disease, obviously, in a few minutes, is understanding what does the gene variant do and how we can make sense of it and respond to it. So some of the gene variants make you have less vitamin D receptors transcribed. Well, resveratrol, which is from red grapes, or sulforaphane, which is from 3-day-old broccoli sprouts or broccoli seeds, and estrogen, which is obviously a human hormone, all can help you increase the amount of vitamin D receptors that you have and can help with things like osteoporosis and autoimmunity and cancer and all those things. So that's kind of explaining how that works. So epigenetics is just really understanding what's going on with someone's genome and how can we respond. But vitamin D receptor SNPs, they would not be something that would show up on whole genomic sequencing, because having 2 copies of any of those ones I talked about is usually found in anywhere from, depending on which one, 5% to 14% of the population. And whole genomic sequencing sounds like the best name. I mean, it sounds like, well, I want that. I want to get it all.
I want everything.
I want it all. We're all, you and I are both that personality. We want to know as much as possible. But the problem with genomics is you can only use a test if you know what to do with it. And the PhD science world of whole genomic sequencing, their mission is to help identify pathogenic disease-causing variants. So on those 3 million base pairs, they will record and report on any of these SNPs that are pathogenic, cause diseases, and they will report on things like a whole piece of DNA missing or an extra piece that's been inserted. And there's lots of things that can go wrong, and things that are associated with really serious diseases, muscular dystrophy, and all kinds of serious diseases where children are seizing and important things. But for the average person who has gotten through life and they're already in their 20s, 30s, 40s, 50s, 60s, 70s, they're not going to learn much from whole genomic sequencing because they probably don't have a pathogenic gene variant that is of importance to them, or they would have figured it out. And what they need to understand is chronic disease. And that is not the world of PhDs. This is the world where I must say that I and my IntellxxDNA team is pioneering is medical genomics. So in 2015, President Obama had the Precision Medicine Initiative, and he called out, we need to start using precision medicine. Specifically, there was funding for using it in cancer to make people's cancer chemotherapies and therapies more specific, and cancer research more specific for what was going on genetically, and for drug pharmacogenomics. And so that's been around for a while. The next phase, which sort of got ignored by public research because there's just changes in priorities of research for that government funding, et cetera, was to make genomics useful for chronic disease. And that was something that I was really excited by. And so that is what my co-founder, her name is Carol Village, and I took on as our mission is, can we take somebody's genome and figure out what gene variants in the literature are most highly associated with cognitive decline, with heart disease, with diabetes, with obesity, with depression, with autism, with many, many topics, and actually map them out, figure out what the gene variant does, figure out how we can respond with diet, lifestyle, supplements, and medications, and will it work? And the long story short, that was back in 2016. It rapidly became apparent that it was working. We were able to demonstrate significantly improved cognition in patients who had mild cognitive impairment or even early dementia. We were able to demonstrate have wonderful effects in people who have issues like autism and mental health, and areas where you can't really do any blood test because of the blood-brain barrier. But then also we were able to have people who have strong family histories of heart disease and be able to understand the contributing factors, and even be able to say, wow, even though you don't have high cholesterol, you might want to do advanced testing like Clearly or other advanced testing because you have this, this, and this going on.
Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol. Then there are fans of a ketogenic diet. There are many anti-meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on-demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is OWNER20, and I'll see you in the office hours. This is fascinating, and I have to tell you, you're 100% correct, because I recently came back from the European Society of Cardiology meeting, and there was a lot of genetic presentations. And in cardiology, maybe 10 to 15 years ago, maybe a little bit sooner, we were very excited about something called polygenic risk scores, right? And polygenic risk scores is essentially adding these SNPs, let's call them, sort of the whole bucket, adding them together. It's not a simple just 1 + 1. It's actually something called computational biology, because it has to account for the prevalence of this gene in the population, its effect size. But it's less important for an average person to know this. Just know that this is a complex, machine-driven type of a technique. But we were so excited about polygenic disease risk, and it has its role. But what we learned subsequently is that patients who were at the top of the heap for these polygenic risk scores, let's say for coronary artery disease, when we were adding that information into what we already have known, which is their biomarkers, their imaging data, There was some additional improvement in risk stratification, but it wasn't off the charts, right? It wasn't something where we would say, it's radically redefined what's happening with a patient. And having done a lot of those polygenic disease risk scores, and I still do them, I began to understand why, because these actionable points, SNPs are actionable. So SNPs are actionable, and they are, I call SNPs, they're sort of like a point of influence. You can influence what's happening with an individual using the SNPs. And I think, the whole genome sequencing, you're right that it mostly has its application. And that, again, what I realized listening in the meeting is that there are companies right now that are using gene editing or gene substitution. Even in cardiology, there's a company called Verve Therapeutics, recently acquired by Eli Lilly. And what they did is that they essentially edited a gene for people who are suffering from familial hypercholesterolemia and having recurrent vascular events to radically drop their cholesterol, because that's the only way, unfortunately, for those individuals. It's a receptor defect. And they showed great results, and they're moving on to test this technology for lipoprotein little a, right? So this is where I think this whole genome sequencing, because if there is a gene substitution, we need to insert the gene into an individual to restore some very important function, disease-related function, as you mentioned. Like, we have a friend of a friend who suffers from Huntington's chorea, absolutely devastating neurological disease. And so for those patients, this is where there is now an opportunity, right? But for majority of
Absolutely.
regular folks with these non-communicable chronic diseases like hypertension, dyslipidemia, heart disease, even Alzheimer's, there isn't going to be much gained by the whole genome sequencing. Do you agree?
I 100% agree, because think of it, the whole genome sequencing looks at things that are generally in at least less than 1 out of 5,000 patients, and often things that are in like 1 out of 100,000. So it's looking at rare things. And so even though they may sequence the whole genome, it's not designed to help a physician understand how do you address this person's heart disease. And a lot of the gene variants that are associated with heart disease, of course, the majority of them are not rare. They're going because heart disease isn't rare. Diabetes isn't rare. Hypertension isn't rare. But there are a lot of different causes. You mentioned hypertension. And even before we talk about heart disease, that might be a really fun genetic topic to talk about, or genomic topic.
Let's do it. Let's do the hypertension genomics. It's a great topic.
So we have a system in our body that is, it's meant to protect us against if we get, injured and bit by a tiger and we're bleeding, it's to raise our blood pressure. But if you have a system that is over aggressive and there's a lot of checks and balances, and it's called the angiotensinogen, renin and angiotensinogen, aldosterone pathway, the RAAS. But if you have problems in this pathway that make it so it is overactive in any of these different checkpoints, you're going to overraise your blood pressure. Part of it, some of those pathways might be salt sensitive. Some of those pathways are going to respond really well to classic drugs like ACE inhibitors and angiotensin receptor blockers. Right. But there are other genes that contribute to hypertension that relate to inflammation, TNF alpha, when it's combined with oxidative stress. There is a gene that relates to mitochondrial regulation that can affect hypertension. And so if you have those driving your hypertension, then it's going to be completely different ways that you address it. And in fact, one of these genes, it's called NETL, it makes people less sensitive to salt. So I have a patient, and he might be a fun patient as a case who came to me after he had a heart attack, unfortunately. But he came to me because he was 61 years old and had just had a heart attack the previous year. And he did not have high cholesterol, had a little bit of high blood pressure, but it was under pretty good control. Did not have high blood sugar, and was just trying to understand what had gone on. And the first thing was, what has his doctors done, which is kind of classic, nothing against cardiologists, but what do you do for anyone having a heart attack? Let's get his LDL down to like 46.
Yeah,
And
exactly. Less than 50. LDL less than
right,
50.
right. He didn't have high cholesterol to start with. And let's put him on a low salt diet. Well, his genomics, the number one thing that was contributing to his cardiac risk was his inability to make glutathione. So just for our
Interesting.
listeners, glutathione is what we call an antioxidant. So if you think of an apple, when you cut an apple in half, it can turn brown pretty quickly. But if the apple is intact, it doesn't turn brown that quickly. And that's because fruits and vegetables have their antioxidants in their skin. So fruits and vegetables last a fairly long time, as long as you don't damage the skin. Humans and all mammals, we have our antioxidants in our blood and in our muscles. But if you can't make the most important antioxidant of glutathione, that's associated with 3.2 times the risk of heart disease because we need to protect our heart from oxidative stress. Additionally, this guy couldn't make CoQ10. Now, these are not common gene variants. They are found in less than 10% of the population, but he had both of them. So, but they're still common compared to whole genomic sequencing. So actually the glutathione one's found in about 11%. And so the combination, maybe 4 or 5% of the population would have had his combination where he couldn't make CoQ10 well, couldn't make glutathione well. He had a few other little things, but by putting him on statins, which create oxidative stress because it depletes your CoQ10, not having him replace his CoQ10, he was told you can take CoQ10 if you want to by his cardiologist. And that was not a good regimen for him. And then they told him to go on a low salt diet. And so again, that didn't help him at all. It was when we lowered his oxidative stress, his blood pressures stayed great. And so he also was having lifestyle things. He was working with chemicals. He had hobbies where he's working with metals and chemicals and on cars.
Interesting.
He needed to be wearing a mask. He needed to be wearing gloves. He needed to have proper ventilation. Now, that's a really different cause of cardiac disease that you wouldn't be able to get at with standard testing and would have changed your what you do. And then you mentioned LPA. I had another patient come to me. Now she was more proactive. Her father had horrible heart disease, horrible heart failure. We actually, I'm happy to say, fixed her father in terms of there's a number for heart failure that pro-BNP. Obviously, it should be low, ideally less than like 150. His was over 1100 on all the medicines and had been 1800 like a few months before. Just so you know, he's now 175. So
nice,
because
nice job.
We understood what's going on with his genomics, but she came proactively. But for her, inflammation was super important. But this very specific type of inflammation that's called, again, don't worry about the alphabet soup. It's called interleukin-1 receptor ligand-1, which makes this protein that stops inflammation in the heart. And hers was floating instead of in the heart. So instead of statins being what she needs for prevention, we need things that lower the inflammation. Although statins do also have some effect on that solubility too. So
on that topic, it's very interesting because I think where we're going to find perhaps, hopefully, a wider application of genomics is when we go after pleiotropic effect of certain common medications, right? So statins are one of them. They're known to have a pleiotropic effect, this, sort of vascular lining stabilizing, plaque stabilizing effect, anti-inflammatory effect that is not really dose dependent. And then we now in the era, of course, of GLP-1 receptor agonists and dual and triple incretins. And I just, some of the cardiac studies that are coming out are showing that there is a direct vascular effect. Again, it's an anti-inflammatory effect, which is independent of the amount of weight loss. And I just literally saw an article briefly in, I think, Journal of American Medical Association that showed that there is a specific genetic combination that could actually predict who will respond to these medications with appropriate level of weight loss and who may not, right? And so there now we are able to even gauge, which direction it goes. And I think this is where we need to go. We need to go into this personalization opportunity. And I think inflammation and detoxification, and we check for it routinely. Obviously, this is sort of oxidative stress is foundational to heart disease, to I guess pretty much all non-communicable chronic diseases, right? So we have even learned that inflammation is now occurring using imaging techniques, and this is another fascinating area. We learned that inflammation is now occurring in the fat deposits that are around coronary arteries or around the myocardium. This is called ectopic adipose tissue, which basically means fat somewhere else, and abbreviated as EAT. And we have learned that there are different levels of this inflammation that are driving progression of coronary disease, atrial fibrillation, heart failure, especially heart failure based on obesity. But what I wanted to say is that another thing that I'm sure you had seen in your patients, and I'm wondering your thoughts on this. There has been a lot of talk recently in more traditional oriented medical, literature circles, that one of the main drivers of hypertension is high cortisol, right? So hypercortisolism, right? And, we see it sometimes in patients who have, Cushing syndrome. It's sort of like a very, kind of a fairly rare, but, very significant endocrine dysfunction. But what I find as a practitioner is that there are definitely people who are in that high cortisol state, and a lot of it is genetically driven.
Absolutely. And so you mentioned two things that are really common genetically. So the first one you mentioned was the people who would benefit from the GLP-1s and the incretin drugs. The reason so many people benefit from that, the number one gene related to diabetes, and of course your blood sugar directly relates to cardiac health because you can glycosylate, you can put sugar on molecules in your body, and that's not good for it. It creates inflammation, is this gene. It's called TCF7L2. That one was on 23andMe. It was the only gene they reported on related to diabetes. And more than 45% of the population have one copy. Now, it's only about 9% of the population that have two copies, but it actually codes for incretin. It codes for the first incretin, GIP, which is one of the things that's in tirzepatide.
Right.
And so for each copy of it, you make 35% less. So people who have that, and again, it's 40-some% of the population, they're not making much incretin to start with, and incretin's a benefit. But the other one and so again, knowing that's really helpful because they can choose. Do you want to either eat a lot less carbohydrates because you can't metabolize them without incretin? Or do you want to replace your incretin? Do you want to take things like Akkermansia and have your gut make more? Or do you need to take a GLP-1 because of your other cardiac and your blood sugar and other risk factors, weight? But with the other one that you mentioned, the cortisol, at the very top of our hypertension panel, one of the main gene variants that relates to hypertension relates to your adrenaline receptors. And the majority, it's actually a benefit if you have less active adrenaline receptors, because that keeps your blood pressure low. In fact, those people can have very low blood pressure. And the reason it's called a benefit is there's something called the major and the minor allele, and it's just like the majority rules. So if the majority of the people have something, then the gene variant is called a benefit. If the majority of the people don't have a gene variant, then it's the minority one that causes the problem. So that's the risk allele. So most of the time, these things we're talking about, we're looking at, oh gosh, this gene is a risk for this. It's less common. But the adrenaline receptor being overactive is a little over half of the people. And so that's a very big contributing factor. And that's why, again, those of us in the integrative world, that we'll talk to our patients about exercise lowers adrenaline, meditation or yoga, ashwagandha, and all of those things can also help keep your blood pressure lower. So it's really fun because what happens is I get back someone's genomics report. I'm sure you see the same thing. And it's almost like you can kind of tell their story beforehand. I had one fellow physician who asked me to look at his report and review it with him. and he was already 70. And I looked at
Okay.
it and I said, and he had genes that affect vitamin C metabolism, and it's glutathione and vitamin C can have really big effects on cataracts. And then he had a lot of genes that affected heart disease, genes that affect LP little a
Mm-hmm.
and plaque buildup, cell adhesion molecules, all this stuff. And I said, and the ones that we talked about, the inflammation combination can give you 5 times the risk of heart disease and heart failure. And if you know that, you can be watching, you can check different blood tests and you can be watching with Clearly and things. And he had all these things. And I didn't know his history because he didn't fill out the form. He just kind of said, hey, can you?
Here's my profile. Take a look.
Yeah, he had ordered his genomics and then said, oh, can you, kind of help me look through it? Because it was his first one. It's common that doctors will do it first on themselves. And I said, before you tell me your history, I'm just curious. Have you ever had any problems with cataracts or heart disease? Because you're really at high risk for both of these. And he just
Mm-hmm.
got this blank stare on his face. And he goes, I've had really bad cataracts since I was in my late 40s. And
Wow.
I had quadruple bypass at 60. And so it's really, I don't want to say it's fun to give people news that they're at risk for things, but when you can be proactive and you can also show that this isn't your fault, but let's talk about how we can address it, it's very empowering. And by addressing it and identifying it earlier, or even in someone who's already had a primary event, I believe it's really beneficial for us preventing further events.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self-ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self-ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. It's important for our listeners also to understand is that when it comes to complex diseases like heart disease, heart failure, arrhythmias, brain diseases like Alzheimer's, dementia, or similar type of dementias, neurodegenerative diseases, under most circumstances, these chronic non-communicable diseases, the genetics is not predicated on a single gene, right? As you said earlier in our conversation, these large effect size pathogenic variants, they're actually quite rare. So in cardiology, for example, familial hypercholesterolemia, what we call homozygous individuals who are born with 2 defective copies of one of the major genes that allows them to clear LDL cholesterol from the bloodstream, they get heart disease very early. They walk around with laboratories that are just off the charts, very high LDL cholesterol levels. But this is not the norm for majority of people. And even for lipoprotein little a, people who are in a very high elevated kind of genetically predisposed to producing higher plasma concentrations, which of course correlates linearly with heart disease and even aortic calcification. This is also not the majority, right? But what's important to know is that for the most people, and I think this is what I'm getting from our conversation, for most people who don't have necessarily these, as we call them, zebras, they still have variants that are very impactful because when you align what you're doing to sort of overcome the gaps caused by your genetics, right? When you align your genomic intervention the right way, as you said, medical genomics, you can actually get results. And this is very actionable.
And I think the other thing is you get insight. So you mentioned LP little a. So having super high LP little a's is relatively rare, but about 5% of the population have a gene variant that still more than doubles, almost triples their risk of heart disease due to one copy of an LPA associated SNP. And in the Hispanic population, it's even higher than that. And so why do we care about it? Well, again, what IntellxDNA does is we kind of go, well, what does that do? Well, LP little a normally has a job of stopping microclotting in the
Yeah.
body, in the heart, and in the blood. And if you can't stop those microclots, so it activates something, tissue plasminogen activator, which is kind of like a clot buster. If you know that you can't do that, they know from studies. There was a study that was a very large study done on women, the Women's Health Initiative. They looked at the women with the specific LPA little variant associated with that high risk of heart disease. And in those women, taking 100 milligrams of aspirin 3 times a week, so it wasn't a high dose, decreased their risk of heart disease more than 50%. It was like 55%. But in women who didn't have it, it only decreased at 8%. So sometimes people kind of go to and do what I call the GNC approach to their health, which means they go to a pharmacy, they go to, a nutrient store, and they go, oh, and they talk to the clerk, and the clerk goes, oh, this is good for the heart. This is good for the heart. This is good for the heart. That's not what you want to do, because one person might need things that boost glutathione. One person might need something that affects there were sirtuins. Another person might need something like aspirin. A statin might be really good. There's even genes that predict who benefits most from statins. And statins can be very good for people with high, what are called cell adhesion molecules. There's another protein, again, it's called KIF, that those people get really good benefit from statins. And so I think that the reason that patients have turned to biohacking is because they've had a hard time finding physicians that can really help them in a precision, personalized way. And what we have tried to do as our mission at IntellxDNA is say, let's stop labeling people with these broad categories of disease, and let's instead start looking at the root cause. It's really important because sometimes not only are we labeling people with diseases, we're blaming them. There's a lot of genes that contribute to obesity that when you understand the risk for them, instead of labeling it, you can then respond better. There's a lot of genes. There are genes. I have one patient. She has 2 copies of a gene called ENPP1 that makes you have over 6 times the risk of diabetes. It also can increase the risk of atherosclerosis, of heart disease. And she was exercising and eating well. And, she wasn't perfect, but again, she wasn't overweight. And she couldn't understand why her hemoglobin A1C would run high. Well, when we got her genomics back, there was so much insight. Then we were able to, using a glucose monitor, be able to see that her blood sugars were just high all the time, because this is a regulator that doesn't allow the insulin and the sugar to enter the cell. So it's hanging out in the blood where it's dangerous. Well, once we knew that, metformin, which again, I use a lot of natural supplements, a lot of diet, a lot of exercise.
But sometimes metformin works.
Well, this particular gene that's overactive is downregulated by metformin. So we could, with a glucose monitor, a continuous glucose monitor, one of those little patch things on her arm, we could see literally in less than 48 hours, all of her blood sugars dropping more than 20 points. And since she was only starting in the 120s to 150s, that was huge. And then we got virtually all of them under 100, except after she ate. And then they would go up in a more appropriate manner. So for her, with that 6 times the risk of diabetes and that higher risk of heart disease, her father had quadruple bypass at 57. It made complete sense to be able to have a conversation about medications, even though she comes to me because she likes the fact that I also use an integrative approach.
Right. So this is a great point, because we're finding the same. For example, very often patients come to us with an intention to reduce or eliminate the use of statin medications, right? So statins are sort of a thorny subject. There are pros and there are cons, but it's not uncommon for us to start detecting some of these early signals of increased diabetic risk in statin users, who especially tends to be more common in women than men. But if they've been taking moderate to high doses, which is the official cardiology guideline endorsed recommendation, moderate to high intensity statins, titrated to the level of risk, we find that over time, 10 years into it, 15 years into it, sometimes shorter than that, we have these first signals of insulin resistance, and beta cell, sort of beta cell, as we the best way to explain it to patients is like beta cells sort of gotten tired of this, and they say enough is enough. And so what genetic testing allows us to do is that we understand what are the predispositions that this individual has to insulin sensing, to glucose regulation, to beta cell dysfunction, and what specifically how their lipid pathways work, because then we can lean in a less medicated way, and sometimes through different medications to actually get them to the right place.
Absolutely. When you're talking about the blood sugar, you mentioned beta cells, which are in the pancreas, and there are genes that relate, there are glucose sensors that relate to beta cell function. For those people, alcohol is really detrimental. And there are things they can do in addition to alcohol to help protect the beta cells. But there are other people where their diabetes risk relates more to protecting their mitochondria. So that's like alpha lipoic acid and CoQ10 and PQQ. And so again, by having that map of you're going to be able to say, okay, let's come up with a plan. What are the most important diet and lifestyle things? For some people, it's low saturated fat. For some people, intense exercise can have disproportionate effects on their blood sugar and their weight. And for other people, there are very specific supplements, but they're not all the same. And so all of a sudden you get to know your body and you can choose how do you want to help prevent chronic disease or address it. But it also, and I know that you're a cardiologist, but it also, I think, has been really, really helpful in brain health, because heart health and brain health.
Heart and brain. Oh, they're twins. They're cousins with twins.
So many people that come to us thinking they're getting Alzheimer's. And when we look at their genomics for their brain health, it is all really, really high brain ischemia related gene variants. And on our IntellxxDNA website, there's a webinar I did with Dr. Bredesen on Clotho. I think it's on the patient friendly part. If not, it's on the physician friendly part, but you can still access it. It just might be a little sciencey and has a big turtle on the front. But there was a person that was trying to do the Bredesen protocol. For those of you who don't know, it's a protocol where you're doing all these things to try to optimize your cognitive health, but he wasn't getting better. He was doing a keto diet. He was doing all these supplements, and he was getting brain fog that was pretty significant when he was traveling internationally. Well, his big risk was hypercoagulability, meaning his blood was too thick. He had something called factor 2 and factor 5. That's a really big deal. When we put him on, he hadn't yet had a blood clot. And I say yet because he has 5 to 7 times the risk of a blood clot.
He was working on it.
He was working on it. But when we put him on things that thinned his blood, and he chose to use non-prescription, and he's doing quite well. We're watching his fibrinogen and all those things. But he chose to use something called lumbrokinase and lumbrokinase and nattokinase. They've got good studies in the literature. And he chose and something called pycnogenol. But anyway, brain fog went completely away. And so you can't tell what the risk is. But here's the thing. What we're finding is a lot of the people with soft plaque, it's because they have those same genes that cause hypercoagulability along with genes that cause cardiac inflammation. So soft plaque is not necessarily the people who have the high LDL. We also know that the genes relating to vitamin K2 are really important to heart disease and so easy to overcome. So there's so much, and there's so much we can do that I feel like it's a very worthwhile investment in your health to work with a physician like you, Dr. Druz, who can help
thank you, Dr. Sharon.
Yeah,
so we are expanding, and we eagerly use these tests and sort of map out all of our patient trajectories, and there's so much information. But let's give our listeners sort of some maybe what are the top 5, Dr. Sharon's top 5 genes that you would advise patients with heart disease to know where they are, right? Because as you mentioned, it's all testable. There are a variety of genetic panels. The type of panel that Dr. Sharon is mentioning is medical genomics panel available directly through physicians. I'm one of those physicians. And there are, typically this type of genetics is not something that one would get access to in direct to consumer offerings. So you do need to kind of go the medical route. So what are the top 5 that you would say if you're a patient with heart disease, you have a calcium score, you should know these top 5? Let's hear them.
Let's start with the number one that you can get from 23andMe. You can get from everywhere. And if you've done almost any genomic testing, this
you'll
one
get it.
And it's called, in the old reports, people used to call it 9P21, but its current name is CDKN2A. And the reason it's so important is 40% of people have one copy, about 45%. And again, only about, 15, 20% would have 2 copies, but it's still a huge number. And it's so easy to overcome. It makes it so you accidentally, because it's not supposed to do this, you put calcium in your arteries instead of in your bones. So it has implications for heart disease and osteoporosis. And it affects a protein called matrix GLA. Vitamin K2 helps overcome that very, very directly. And you can take vitamin K2. You can find vitamin Ds with vitamin K2. So that one's easy to find. I do think that another important gene variant is LP(a), but that LP(a) you can measure and understand both from gene variants, and that one you can understand from blood as well.
Right.
The one that you're not going to find in other tests is the one that codes for soluble ST2. It's an interleukin-1 receptor. And that one, the reason I think it's important is that one combines with another inflammatory pathway. And together, that pathway contributes to 4.5 times the risk of heart disease and 4.5 times the risk of heart failure. And it completely changes management. Those people, you're going to watch their markers for heart failure, like a proBNP, and they respond to spironolactone, but you're going to use anti-inflammatories early on, and maybe even things like sulforaphane. But you also, with these people, because they're high risk of heart disease, might be doing more advanced testing. That's to be able to catch soft plaque. Inflammatory plaque is not calcified plaque.
Or check, sorry to interrupt, do a testing which are available in Europe, not so much, here in the United States. There is something called fat attenuation index, which is a CT technique, a CT angiography driven technique where one can measure the amount of inflammation in the fat around the heart or even coronary arteries. And, for heart failure patients, this is going to be a tremendous breakthrough because we'll titrate the medications based on the amount of inflammation in that fat.
Yeah, that's really a fascinating new advance. The other one I would say that, again, you're not going to be able to find on on any direct consumer or other platforms that I know of, because we had to actually work with our bioinformatic person to get access to this because it's a combination, is your haptoglobin type. Haptoglobin has to do with oxidative stress, and people who have the haptoglobin 2,2 can have significantly higher risk of heart disease if their blood sugar goes up, but also if their vitamin C level goes down. And you might start to go, and then I also think the clotting genes are very important, even though they are not so much heart disease, they're brain disease and stroke risk. But I do think that they contribute to soft plaque as well, in combination with inflammation. So I think those ones would be some of my favorites. There's so many, that I like for different reasons. But I think that the thing to realize is you only get one body, and anything you can do to optimize it makes sense. And a lot of people, their concern with using a physician-guided genomics is it is a little bit bigger investment than ordering a $200 direct-to-consumer kit.
Yeah, these are, let's talk about this. These are pricey tests. They could go $2,000 plus. So this is somewhere in that area.
And that's not necessarily the cost of the test, but it's because you're paying for the test, and then you're paying for your doctor's time to go over the test. So you may be investing a little bit more. The test itself is a part of that cost. But when people are asking me or asking any of our physicians, should I do it because it seems expensive, what they're really asking is not about the cost, but is it going to give them information that is different and actionable and going to help them in their life? And again, we at this point have enough studies, enough data back from our clinicians showing how we've improved brain health, showing how we've improved overall health. Heart health is a little harder to prove,
Right.
but we can improve blood sugar, people's energy,
Risk factors. We can improve risk factors. We can,
improve the risk
certainly
factors. You know,
reduce the drive to make more plaques or to decompensate on heart
overall,
failure.
we find that people with medical mysteries, they're coming in with pain as a side effect. When we're addressing their genomics, the pain goes away. And that's a whole nother podcast if we want to talk about those kinds of things.
So fascinating.
What I think that you'll find is if you talk to people who've had their genomics done, medical genomics with IntellxDNA, they're very excited, and it's worth it because it's a one-time investment. It's a cheek swab that you only have to do once, and then you use it. You're getting hundreds and hundreds of pieces of data. So you might start with Dr. Druz talking about your heart and your blood sugar and your metabolic health. But then the same test already has information about your bones, information about your brain that you might use with your primary care doctor. And we do free training of doctors, free mentoring. So if you have a doctor who's not trained on it and you want to share their DNA with them and your results, we are happy to train them on it or to introduce you to doctors in your area that are trained for because if you choose to do mental health as well, when Dr. Druz may not want to talk to you about your depression.
No, I may have to refer out, but I think an important part also, Sharon, is that there are so many people who wish to go onto the longevity track, right? It's so popular right now. Everybody wants longevity, and nobody really knows, what exactly you're supposed to do to get to longevity. There's some good advice. Dr. Eric Topol in Super Agers profiled a couple of areas. Great book to read. There are a lot of other, books. I think Dr. Walter Longo with his longevity diet, given some insights into what potentially are the mechanisms. I decided to write the longevity book. It's in early stages, but, it will be called Longevity Switches. So we'll go through a lot of this information, including genetics. But if you truly, if you're listening to this and you're asking yourself, what can I do, not just only to increase my lifespan, but to increase my health span, which basically means optimize my health, my wellness, my vitality as I age, right? Because all of us are going to age. It's a natural process. It's not about age reversal. It's about age driven optimization. And in my opinion, having done these tests, I don't see how one would go into this age-driven optimization without knowing this information. Yes, one can run off and do whole body MRI. That's not really going to help.
Yeah,
so it's not a longevity tactic. People may want to think that it is, but it isn't. And so the point is that longevity is hard work and to a certain degree, it's a commitment of resources, including financial resources. It's an investment, right? But longevity is a process. It's a marathon, and this is such an important part of what an individual needs to know that I don't think anybody could say I'm getting longevity care, but I have not had this deep dive medical genomic analysis.
And it can really help you with your longevity plan. So there are a number of genes associated with longevity, but if you look at the blue zone population, there are 5 in particular that have been highly associated with longevity that are overrepresented in the blue zones. And those are in our IntellxDNA reports. When you order an executive report, you're going to get information regarding klotho, which is the number 1 longevity protein. But klotho is not just about longevity. People who have low klotho, they could benefit much more from aerobic exercise, and resistance training is not good for them. Resveratrol is particularly important for them. So you get real specific things. But then there's a nutrient sensor that is more related to heart health that is also associated with longevity. And there are other, even ApoE2, which is the opposite of ApoE4, that's a longevity protein. But what can you do if you don't have ApoE2, if you have ApoE4? So longevity is the science of knowing yourself and how to understand your risk factors. But macular degeneration risk, diabetes risk, osteoporosis risk, stroke risk, all of those to me are super important for longevity. And of course, cardiac risk. And even, we didn't really talk about cancer. Most cancer is not due to cancer pathogenic genes. It's due to problems with your inability to remove carcinogens, toxins from your body. So what I would say for someone wanting to optimize longevity is you will find that a very large number of the longevity doctors are currently using IntellxxDNA. I am part of there's a longevity doctor groups, and they're finding it very, very helpful. But again, whether you go to a doctor that advertises it as longevity or advertises it as precision medicine or functional or integrative medicine or a holistic approach, the bottom line is if you can know what is going on in your body, then instead of saying, I'll take a little of this and this and this and this and this, you can come up with a precision plan that is tighter, that won't require you to take 20 or 30 different things, and that you can be more thoughtful Dr. Walter Longo, he talks about fasting mimicking diet. It's got definite evidence for cancer prevention and longevity. Yes. But there are people who have problems with their mitochondria that they will get sick if they do fasting mimicking diet. They can't transport carnitine into their cells. So nothing is for everyone. And the more you know about yourself, you can really help to approach your longevity with your DNA in mind.
I agree 100%. And, to our listeners, if you wish to go down that path, Holistic Heart Centers, we offer a full longevity panel. It is based on IntellxDNA. So thank you, or IntellxDNA capabilities. Thank you, Dr. Sharon. And we put a whole longevity sort of pathway together using vascular imaging as well, because that's such an important part of it, not just knowing what you can prevent, but knowing what is happening right now. Because if you heard me speak about this, I always say this, the aging is vascular and, on almost every single level. And so if you want to actually forge a great longevity path, you will have to ask yourself, how do I de-age or de-risk my vascular situation? And
Absolutely.
everything, follows it, the inflammation, the detox, the oxidative stress. Sharon, it was truly a pleasure. Thank you so much. I learned a ton. And, we will have to have you back because there's so much more to discuss when it comes to genetics. This is sort of just like a tip of the iceberg.
My pleasure to come, and I'm happy to come back again. Thanks.
Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Heart Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoy the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.